thinking more on how we could better listen the voice and learn from the experiences that you bring to the conference. We always thought on this symposium on being a practitioner symposium, and that's the objective of our second theme group. So as we have begun a little late, because also the previous group ended a little late, we don't want you to miss lunch. So we are going to begin immediately. I will invite Walter to explain the dynamic that we are going to follow to listen to each other. Thank you very much and welcome.
The situation of the indigenous populations around the world is very unique in the sense that one of the estimates of the United Nations is that there are 370 million indigenous people around 70 countries around the world. And despite in a very diverse countries, what they have in common, all of them, regardless whether they are, is that they have a common history of structural exclusion, oppression, discrimination, and whatever country you go, regardless of is it a low-income country, a middle-income, a high country, they always will have worse health, social, and economic indicators than the non-indigenous population. So you have indigenous population in a very limited resource country in Africa, they have many populations, and they will be much worse off than the general non-indigenous, but you have indigenous population also in the high-income countries. There is data of Australia and Canada and the US, the native population have worse off indicators than the non-native population. So that, what it tells us is that it's not because of lack of resources. There must be, and there is some historical and structural processes that have created this level of exclusion, that regardless of how rich or how poor is the country, still they're going to be worse. So that's why we start by concentrating. There is something common there, and that means that there is a possibility of building something together, because it's not because of money or income. We just heard this morning that this emphasis on the UHC about mobilizing resources, that the issue who is paying for what, but in the case of indigenous population, it's not about the money. There is something. So that's very important. But also we added into this group, we added also other marginalized populations, because there are other populations in the world that, although they are not considered indigenous, but they face similar issues. For instance, Roma populations in Europe, and also Dalit communities, Dalit groups here in India. We just heard in the morning the situation of the Dalit communities. And similar to this one, we will have other population groups that, although they are not indigenous, but there have been some historical processes that they face the same condition as the indigenous population. So that's why in this session we're going to talk about indigenous population, but also in general, that will include other marginalized populations, that there is a historical factor, a structural factor that create that level of marginalization. So that means that one condition is having recognized indigenous, but secondly, for other marginalized, identity is very important. So in terms of marginalization, we can have marginalization because of being poor, for instance, but it's very different. It's very different if among those marginalized that are poor, they also have common identities. That could be either because a specific sub-ethnic group, or it could be because of other factors. So for this session, we are interested not in a general indicator such as just being poor. There has to be something else that gives identity to this group. With indigenous population, but also with these population groups that can be clearly identified through specific identities such as Roma populations and Dalit, countries, but also multilateral agencies such as UN have created a specific legal framework to try to change that situation. So that means that that's another important factor among populations, that at the national level, but at the global level, it has been recognized that this is not right. Something has to change it, because this is not right with this population facing this We had the International Convention of Indigenous Populations, the United Nations. But most countries, if not all, has some level of legislation about trying to correct the historical exclusion of indigenous population, or in the case of the Roma population, the European Union has specific rules and regulations about provide resources, specific resources for Roma population. And here, for example, with the Dalit, we heard in the morning that although there has been specific laws about try to stop the situation of Dalit minority working in the manual scavengers, that's one of the legal problems that have been passing and trying to correct that situation. So that is the second factor, which is very important. That isn't, we have these population groups now that can be clearly identified, and secondly, there are specific rules and regulations at the national, international level to try to correct that. Why is that important? Because that is the entry door for accountability. The entry door is that it's recognized that this is something unfair, unjust that has been happening. And secondly, countries, some of them more than others, but at least most of them will have some basic legal frameworks that would say that this has to change, either because of passing new laws or either providing higher resources to this population. So that is the entry door for the accountability. Of course, just having these laws and regulations doesn't mean that things are going to change. In most countries, we have that despite having passed this law that we're going to prioritize indigenous population and so forth, very little is happening. So here is the entry door that we may start correcting this situation by using broader strategies of accountability, and accountability which is local accountability, but also working on the strategies of legal empowerment, international litigation, and strategic litigation. So that's what we are trying to address in this session.
So at our discussion table, we had participants from Mexico, India, and Peru, and they shared their experiences of the ways in which they try to improve access to quality health services for those in fragile contexts. So conversations revolved around the barriers in accessing this kind of care and the methods that were used in order to overcome them. So they held historical and cultural processes to be responsible for deep-rooted biases within the health system, and how that's perpetuated the level of exclusion and marginalization for certain communities. Additionally, they said that there was a lack of concept or tradition of accountability from the government, which further complicated matters. And very often the government officials themselves are unaware of the laws and rules that are in place and what their obligations are. So in effect, they argued that it's not just the existence of a law that is important, but the way that it is implemented is even more important. Some of the participants shared how poor Indigenous women were discriminated against and mistreated at health facilities because of their cultural beliefs. They shared how Indigenous women were penalized for not giving birth at these health facilities and how they were threatened with the prospect of their children not being registered as citizens. So in a way, they're just trying to emphasize how the government actually poses a barrier. Like the government wants you to come and give birth at a facility, but they don't respect your right to maybe not have one, or even take that additional initiative to kind of educate you or make you more aware and make you more comfortable about giving birth at a health facility. The participants from this table also emphasized the importance of taking a people-centered approach and building capacities of the vulnerable communities, so as to effectively monitor health policies and services where they are located. The concerned communities were trained in accessing information, understanding government structures, collecting evidence from the field, and advocating their demands to different stakeholders. The discussion ended on a positive note wherein a participant remarked that previously she used to think of healthcare as a favor, but today she thinks of it as her right.
So at our table we had people from very different regions of India. We had Alakriti from Meghalaya in the northeast. We had Lakshmi from Rajasthan in the north. We had Monica from Bihar. We also had Ola from Nigeria, Danilo from Brazil, myself from the UK. And the discussion covered, there was quite a lot of discussion about the role of traditional healers, indigenous knowledge, indigenous practices, people sharing local practices, local perceptions, and we had quite an interesting discussion around the herbal and sometimes the psychoactive substances that are used in traditional healing, and also the use of alcohol in traditional festivals, and how these lead to a stigma, a perception of indigenous peoples as using drugs or having too much tobacco and alcohol use. And there was a lot of sharing around the importance, for instance, of tobacco in social situations, of knowledge sharing in northeast India, and of coca leaf, chewing the coca leaf among shamans in the Amazon and so on. So there's a lot of need to push back against stigma of traditional practices involving these substances that the rest of society regards as sinful or harmful, which are often important in healing. We did talk a lot about coordination communication in many different ways. Obviously, coordination communication between indigenous peoples and the health system and health professionals, between the community and the government, but also between levels of government. So Ola was sharing a lot how local government, there's a lot of participation and engagement at local government level in Nigeria, but there's no communication at the state level, and all the money stays at the state level, and it's very hard to make that connection. Everything is very centralized, and it's very hard to reach those other levels. And also similarly in indigenous health in Brazil, a lot of decisions made in Brasilia, so participation at the local level doesn't help very much. But also the question of coordination between sectors. So some of the things people are working on, menstrual health, for instance, Lakshmi's NGO has worked a lot on access to non-plastic-based sanitary products, and making them available in schools. And that means working with the education department, and that's very difficult because you're talking about a health issue, but a sensitive, highly politicized health issue in relation to an education department that's not prepared to talk about it. Monica's work on nutrition, which of course relates to other sectors as well, so the need to work intersectorally was emphasized. And finally, there was a lot of discussion around what does it take. Sometimes the state does listen, sometimes there is change, and what does it take for that to happen? So Ola shared some stories about building political will in Nigeria, using elections as windows of opportunity. Oh, now he's here. Talk about using elections as windows of opportunity to get attention to priority health issues which have been neglected. Also, Lakshmi shared that in northeast India, the fact that there's a lot of, I think, and Lakshmi also, that there's a lot of concern around environmental issues, means that you can frame issues around indigenous health in relation to the environment, and you can build alliances in that way. So there's a lot of discussion around allies, not just different sectors of government like environmental agencies, but also the role of scientists. IIT Madras was acknowledged as a partner valuable in helping Jatan Sanstan legitimate non-plastic based sanitary products as an acceptable menstrual health strategy. And finally, there was a lot of emphasis on the need for data to convince government and how researchers can be allies in producing data and helping movements and civil society groups convince government of the need to change.
Several of the things that we discussed in our table are already being addressed by the other groups. So first I would say that we had participants from Nepal, India, Mozambique, and myself from Peru. And we discussed, one of the main issues we discussed was the changing roles of advocates while working with indigenous communities. Maybe at the start it is around visibility, making them more visible and their needs, and in conflict areas that have suffered conflicts, to implement the first health services in the area. And when this happens, after a few years, our role changes, and it develops into being making visible the areas and the services needed to further achieve population right to health. We also talked about how having a specific legal framework for indigenous peoples, like community rights and different rights and the rest of the population, is an entry door for accountability. It is an important tool, but it's not enough. We need community mobilization, social participation in order to make these good laws happen for the people, no? Because we all have either national laws or international commitments that are very good, but they don't work. They don't really work for indigenous people because they are not realized in the field. Another role that we discussed was the mediation role of ourselves as practitioners to help further the communication between service providers and indigenous people receiving the services. And also a role as capacity developers in both sides, so they can, for example, a woman in our group was involved in training indigenous tribal communities in the use of media to further their advocacy work, and at the same time training the service providers to understand better the particular needs, the specific needs of the communities that they serve.